Good afternoon, everyone. Today I'll be discussing about the topic of emerging theranostics for prostate cancer. So before I begin, I would like to express my sincere thanks to Dr. Ameya for giving me this opportunity to present in this scientific forum. Uh, with regards to the disclosures, I do not have any conflicts of interest to disclose. But at this juncture, I would like to acknowledge my thanks to Professor Michael Hoffman of Peter Cancer Hospital for sharing with me the details of the several trials that have been conducted at the Peter MacCallum Cancer Hospital over the last few years. Theranostics is a familiar word to all of us, and it is formed by the combination of the words therapy and diagnostics. In the process of carcinogenesis, the cancer cells show certain genetic markers or cell surface or circulating markers called as the biomarkers, and we can make use of these markers for the diagnosis of the cancer. Many a times in many cancer cells and many types of cancers, we can even target these markers, especially the genetic markers, to try and control the growth of these cancer cells, and hence the combination of detection of a particular marker and using that for treatment of the cancer as well gives rise to the term theranostics or the concept of theranostics. In nuclear medicine, uh, we have been witness to this wonderful concept of theranostics for several decades. And the first and a very beautiful example of theranostics has been radioiodine therapy, wherein we can diagnose carcinoma thyroid by using iodine 131 for scanning and as well as treatment of thyroid cancers. There have been other examples of theranostics in nuclear medicine, such as the radioimmunotherapy for lymphomas, bone seeking agents, and then somatostatin receptor imaging and therapy for neuroendocrine tumors, and of late the PSMA diagnostics and therapy. Prostate specific membrane antigen or the PSMA molecule is a cell surface molecule which has enzymatic activity, and several traces have been developed to target the PSMA molecule. The first tracer which was developed was the 7E11 antibody. This unfortunately was targeting the intracellular component, and which was not very successful unless you had necrotic or dying cells wherein it can bind to the intracellular component. But recently there has been development of targets to the extracellular component, such as the J591 whole antibodies, and the development of small peptide molecules based on urea, such as the PSMA molecules. So I will be discussing about recent trials in theranostics in the prostate cancer and combination treatment strategies that can be used or that are being developed for prostate cancer in the field of nuclear medicine. We have a wide array of tracers which can be used for diagnosis of prostate cancer, such as the PSMA11, F18 based tracers such as the PSR and PSMA1007 and so on. And when I did a search on the clinical trials website for trials on PET in prostate cancer, I could see more than 180 active trials which are recruiting on the role of PET in prostate cancer that are currently being conducted. So the scientist is not a person who gives the right answers, but he is the one who asks the right questions. So we will try to address some of the important questions in theranostics in prostate cancer in the subsequent slides. The first question which we are going to address is how the PSMA PET compares with conventional imaging modality. So one of the landmark trials which deals with this particular is the Pro-PSMA study, which was published in the Lancet. So coming to the details of the Pro-PSMA trial, this was a multi-center randomized trial conducted in over 10 centers in Australia, and all the patients enrolled in this trial had a histologically confirmed diagnosis of prostate cancer and no staging imaging done prior to enrollment. The conventional imaging arm in this trial included bone scan and the CT scan, whereas the comparative arm was the PSMA PET scan. And the primary endpoint that was analyzed in this trial was the accuracy of the imaging modalities. The secondary endpoints included the impact factor of the imaging modality on the clinical decisions, and number of equivocal studies, or the percentage of equivocal studies, and the radiation exposure from each of these studies in the arms. So if after being randomized into one particular arm, if the patients were noticed to have less than 3 metastases on staging procedures, the patients selectively underwent crossover to the opposite arm as well, and then the accuracy of the second line imaging and the impact of the second line imaging was also estimated in this particular trial. So when we look at the results, we can see that the accuracy of the PSMA PET was much better than the conventional imaging arm, and the impact of the imaging modalities was analyzed by giving a questionnaire to the referring clinician, and before and after the investigation was done, to see how the management was impacted. So the impact of the management was also much higher with the PSMA PET scan, and the number of equivocal studies were much lower in the patients who had a PSMA PET scan. The radiation burden was also much lower in the patients who had a PSMA PET scan. We can see the details here. Again, the area under curve for the PSMA PET is much higher, seen in the red. We can see that the radiation burden in the bottom, we can see that the patients who underwent a PSMA PET scan received up to a total of 9 millisieverts, whereas with the combined bone scan and the CT contrast CT scan, the radiation burden was up to 19 millisieverts in these patients. So this trial definitely documented the superiority of the PSMA PET scan for staging compared to the conventional imaging. Now, if we come to the detection of the prostate cancer, we have multiparametric MRI, which is a very beautiful test, and we can characterize the lesions beautifully on the several stages or the components of the multiparametric imaging. However, if the multiparametric imaging shows certain grades of pyrites, especially the pyrites 2 or pyrites 3 lesions, the chances that they are false positive is quite high, as evidenced by this particular trial which was published in the Lancet. And among 418 patients who were deemed to be of having a clinically significant prostate cancer on MRI, almost half of them were negative on biopsy. So this is one of the shortcomings of multiparametric MR imaging. So the next question we try to ask is, if now we know that PSMA PET is very good in staging, is there any additional value of doing a PSMA PET along with an MRI for diagnosing prostate cancer? This particular was addressed in the primary trial, which is published recently in the European Urology Journal. So the patients recruited in this trial had a suspicion of prostate cancer with elevated PSA and a positive digital rectal examination. Almost 296 men with suspected prostate cancer were included in the trial. They underwent multiparametric MRI and a biopsy and a PSMA PET scan. The primary endpoint in this trial was to see if the negative predictive value of MRI could be improved by combination of the PSMA, by adding the PSMA findings to the MRI. And the secondary endpoints that were analyzed was to see if we can safely avoid biopsy in certain group of patients if we combine the interpretation of both MRI and PSMA PET scan. So when we go to the results, in this particular trial, the patients included in this trial, the negative predictive value for MRI for clinically significant prostate cancer was 72%, and with the addition of both PSMA and MRI findings, the negative predictive value improved significantly to 91%, which meant that you would miss much lesser percentage of clinically significant prostate cancer patients when you combine both PSMA PET and multiparametric MRI imaging. This small percent is due to of course certain number of few small percentage of patients who do not express PSMA receptors in spite of harboring the malignancy. Coming to the secondary objectives, when you have an equivocal report on the MRI as in with the PIRADS 2 or 3 scores, and if you had a PSMA PET which did not show any abnormal uptake, you could probably observe or safely avoid the biopsy, unnecessary biopsy in these patients, in up to 38% of these patients. Now another endpoint which was explored in this trial was to see the positive predictive value of PSMA PET, and an absolute cutoff for the SUV value was derived with a positive MRI of PIRAD scores of 4 or 5. The PSMA PET value showing an SUV of more than 9 had 100% positive predictive value, and irrespective of the MRI findings, SUV of more than 12 had 100% positive predictive value in this particular study. So this calls for including PSMA PET in the diagnostic algorithm, especially when you have an equivocal findings of PIRADS 1 to 3 on an MRI, and you could probably do a PSMA PET scan to decide whether or not you need to go ahead for the biopsy. Now we can again at this point raise a question as to if we can use PSMA PET actually to direct the site of the biopsy and to increase the yield of biopsies in these patients. This is being explored by two very interesting trials. One of the trials is being performed at PGI in India from Chandigarh. They tried to use robotic arm and use the PSMA PET to guide the site of the biopsy using a robotic arm, and the approach was transgluteal approach. The trial appears to have completed recruitment, and we would be eagerly awaiting the results to see how they turn out. Another trial, the primary 2 trial, is also being conducted on a similar line to see the additional value of doing a PSMA PET in these patients and to guide biopsy So the next question which we will be addressing is, what is the impact of the PSMA PET on the management, and can you base your management decisions on the PSMA PET findings? The question here, if you put it alternately, is if you incorporated PSMA PET findings in your management decisions, would that result in better outcomes for the patient? So there are two very interesting trials which are looking at this particular aspect. One is the Oriole trial. This trial actually tried to evaluate whether or not doing a stereotactic radiotherapy in oligometastatic disease improved the outcome. That was the principal endpoint in this particular trial. And of course the results of the trial show that there is definite benefit in doing stereotactic radiation to oligometastatic sites of the disease. As a secondary observation, all the patients in this particular trial underwent an F18PSR PET scan. Now the investigators analyzed if all the sites that were detected on a PSMA PET were included in the treatment, or if some of the lesions were missed because the treatment plans were actually based on conventional imaging and not on the PET. So when an analysis was performed categorizing the patients who received radiation into those who had all the lesions treated and those in whom not all the lesions were treated, again there was a significant difference in the outcomes for these patients. So if when the patients had all the lesions that were treated showed significant better progression free survival and distant metastasis free survival on follow up compared to those in whom some few of the lesions were not included in the treatment plans. So these are the difference in numbers. So this study shows that treatment with stereotactic radiation for oligometastatic prostate cancer improves outcomes, yes, and the outcomes were significantly enhanced by total consolidation of the disease identified by the PSMA targeted PET scans. Another similar trial included the flucyclovin PET, which is an amino acid agent which can detect prostate cancer, and it has relatively high sensitivity for identification of prostate cancer. This trial is called the EMPIRE trial, and this was conducted in patients who had prior prostatectomy with detectable PSA levels. So now these patients were divided into conventional imaging arm versus the flucyclovin PET guided radiotherapy. So the radiotherapy volumes were defined either on conventional imaging, that is CT, or flucyclovin PET. Now when analysis was performed for survival, the median survival was not achieved in both these arms. However, at 3 years, the event-free survival was much better in the patients who underwent flucyclovin PET, and the 4-year failure was also failure-free survival was also much better in the patients who underwent treatment based upon the flucyclovin PET defined volumes. So the conclusion of this study was that flucyclovin PET addition to post-prostatectomy radiotherapy decision making and planning significantly improves survival free from biochemical recurrence or persistence. So these two trials show evidence that if you planned your treatment based upon the PSMA PET, the outcomes could be much. Now we approach the next question. We have seen the diagnostic part of the PSMA, and now we move to the therapy to complete the Theranostics concept that we are discussing actually. So is PSMA based Theranostics a safe and efficient procedure? So we have lutetium PSMA which can be used for targeting the prostate cancer, and we look at the question as to if this particular therapy, how efficient it is and how does it stand compared to the other modalities of treatment that are in use. So a phase 2 trial was first initially conducted in 30 patients who had prior hormonal treatment with abiraterone or enzalutamide and at least one line of chemotherapy in the form of docetaxel. And among these 30 patients, more than 50% or around 57% of the patients showed more than 50% drop in the PSA. Very minimal side effect in the form of dry mouth was seen, although in a large proportion of the patients it was just grade 1 in severity, and grade 3 and grade 4 thrombocytopenia was noticed in just 13% of these patients. So encouraged by the results in this phase 2, a prospective, again a randomized control trial was planned, the therapy trial, which compared lutetium PSMA therapy to second line chemotherapy agent, the cabazitaxel. This trial was published in the Lancet in February this year. The primary outcome in the form of PSA reduction more than 50%, as you can see from the results, is much better in the lutetium PSMA arm, and the treatment with lutetium PSMA also had better progression-free survival at 12 months of almost 20% compared to 3% in cabazitaxel arm. The objective response rates were also much better with lutetium PSMA arm. The side effects less severe and fewer in the lutetium PSMA arm. Another important trial which is recently published in the New England Journal is the Vision trial. Here the investigators compared the lutetium PSMA with standard of care. The standard of care was defined as either bisphosphonate therapy, radiation, or hormonal treatments in the form of abiraterone or enzalutamide, and the standard of care did not include any chemotherapy, immunotherapy, radium, or other investigational drugs. So a 2:1 randomization was done in both lutetium and the standard of care arms. The results of this study also show much better progression-free survival, radiologic progression-free survival with lutetium PSMA as compared to the alone, and again significant better overall survival and higher response rates in lutetium PSMA with complete response in almost 9.2%, partial response in 42% of the patients who were treated with lutetium PSMA. So now both these trials document that Theranostics or therapy based upon PSMA targeting improves the patient outcomes in men with castrate-resistant prostate cancer following docetaxel and androgen receptor directed therapy. It is definitely much active than cabazitaxel in PSMA-avid disease, and it shows fewer grade 3 and 4 adverse effects and improves the quality of life. At this juncture, I would definitely take this opportunity to mention very recently published phase 2 randomized trial from PGI in India again, and this particular trial compared lutetium PSMA with docetaxel in chemotherapy naive metastatic castrate-resistant prostate cancer. And I should take this opportunity to congratulate the investigators for having successfully completed this trial and getting it published. So the results of this trial show that the difference in the PSA response rates between the two arms met the criteria for non-inferiority as defined in the protocol. The PFS and the overall response rate were comparable in both the arms. The quality of life and the adverse effect profile was favoring lutetium PSMA therapy, and they concluded that lutetium PSMA was demonstrated to be safe and non-inferior to docetaxel in the treatment of metastatic castrate-resistant prostate cancer. So it's a very useful trial, and it calls for further consolidation of this information in form of much larger randomized studies. So now we have seen the utility in staging for diagnosis and the impact on the management, and we have also seen the evidence with regards to the efficiency of Theranostics based upon the PSMA. Now there are a few more interesting areas which we can look into, such as, is there anything that can be that we can do to improve the outcomes with PSMA Theranostics? This is a very beautiful slide which summarizes the areas of active research or that can be conducted with respect to PSMA Theranostics. Now we can probably look into areas such as optimal selection of patients by using either radiomics or neural networking and artificial intelligence, try to see if there are any imaging characters that can predict the outcomes, and we can also base our selection of the patients upon FDG avidity of the lesions, and research is ongoing to see which factors favor better outcomes or influence the outcomes on both PSMA PET and FDG PET. Studies are also being carried on to see if the dose that is delivered to the tumor sites by dosimetric studies can influence the outcome of the PSMA therapy. Now lutetium PSMA does radiation-induced damage to the tumor cells, and following the radiation-induced damage and necrosis of the cells, there is release of antigens within the tumor cells into the circulation. Now, one of the important areas which is being looked into is if we can add immunotherapy such as pembrolizumab at this juncture. Can immunotherapy potentiate or improve the outcomes with lutetium PSMA treatment? Now this is being evaluated in a trial called as the PRINCE trial, and another trial which I will be showing in the subsequent slides. Hormonal treatments like enzalutamide, they actually upregulate the PSMA receptors on prostate cancer, and there is a trial which is looking into the use of combination of enzalutamide with lutetium PSMA and trying to see the additional value of hormonal treatments with lutetium PSMA. For radiation induced damage, radiosensitizers or drugs such as the PARP inhibitors, which actually inhibit DNA repair, can be used, and this particular question as to whether there is any role of adding PARP inhibitors and whether it improves, has any influence on the outcomes, is also being looked at in the LUPARP trial. Now there are also other radioisotopes such as the alpha emitters and the Auger electron emitters, which can be used for treatment, and whether they have any different outcomes compared to the lutetium PSMA, which is a pure beta emitter, or not. Again, several studies are being undertaken to look into this particular aspect. Sometimes, as for example in this patient, we can see that there is extensive bone metastasis and few sites of the disease are macroscopic, showing focal intensivity, but there is also a diffuse marrow infiltration that can be seen on the PSMA PET. Following 3 cycles of lutetium PSMA therapy, the macroscopic sites of disease have responded, but the diffuse marrow disease actually continued to progress, and this was also reflected in the PSA levels in this particular patient. And actually the patient did not benefit much from the PSMA therapy. So one might wonder if using a low path length isotopes such as the alpha emitters or Auger electron emitters can target these sites of diffuse marrow involvement much better as compared to lutetium PSMA alone. And if at all, if you are planning to use these agents, should we use it as a combination with lutetium PSMA or as a sequential therapy? All these are unanswered questions. And we know from bone seeking radionuclides that although they are not directly targeting the tumor cells, they can improve the survival of the patients, for example from the data from the radium treatment. So is there a role of targeting the tumor microenvironment and whether that improves or changes the outcomes in any significant way? That is also a very interesting question that can be looked into. And of course there are many new targets which are being evaluated for prostate cancer, such as the gastrin receptors, the FAPI, and somatostatin receptors, especially when you have neuroendocrine differentiation of the prostate cancers. All these are very pertinent and very interesting questions which need further studies to be answered. This table shows multiple trials that are being conducted in Australia with regards to prostate cancer, such as we have discussed the therapy trial, and the PRINCE trial, as I have mentioned before, looks at the role of pembrolizumab with lutetium PSMA. LUPARP trial is looking at the role of DNA damage inhibitors, DNA repair inhibitors such as the olaparib as a combination with lutetium PSMA. And we have the ENZAPI trial looking at the value of adding enzalutamide, which upregulates the PSMA receptors to PSMA therapy. Now, combination of radiation with lutetium PSMA in oligometastatic diseases is being looked at in a Foxtrot 2 trial. Then we have the upfront PSMA trial, which looks at combination of lutetium PSMA with docetaxel versus docetaxel alone in chemotherapy naive high burden metastatic prostate cancers. And finally, but not the least, we also have the lutectomy trial, which is looking at delivering high radiation doses to the primary in the prostate gland prior to radical prostatectomy using lutetium PSMA. we are moving from the last line of therapy to the first line of therapy with our therapy. These are various isotopes which can also be explored to see if they have any additional benefit to lutetium PSMA in treatment of cancer. Example of few of these trials looking at different isotopes and different targeting pharmaceuticals include in the clinical trials website are like the on the actinium PSMA, and then you have iodine 131 labeled antibodies, and lutetium labeled to whole antibody, which I have discussed before, and then copper molecule as a diagnostic and therapeutic agent, the theranostic combination of copper PSMA for prostate cancer, and also there is another trial looking at lutetium PSMA prior to radical prostatectomy. So the future is not something that we enter, but it is something that we create. So it's a very beautiful saying. And with respect to theranostics in prostate cancer, actually I think we are creating a future for a definite role of theranostics and nuclear medicine in the prostate cancer with the right strategies and right studies that are being planned worldwide, and I think we are heading in the right direction. And at this juncture I would like to give a huge shout out to all the researchers worldwide who have made the above studies possible, and to all their teams and the team members, and most importantly to all the patients who participated in these trials to give us this information. Thank you.